I'm Carol Levy. I'm a professor of medicine at the Icahn School of Medicine within the divisions of endocrinology and obstetrics and gynecology. That's a great question. Where do I think we are and where do I think we're going? So right now, in terms of diabetes, what's super exciting is all the advances we've made for all people with diabetes. So what am I referring to here? Let's start with type 2 diabetes because that's the largest number of people in the general population who have diabetes. So in type 2 diabetes, what's really been revolutionary from my perspective is the advances in treatment medically for people. You watch TV now, you're going to see commercials about all these great new meds for people with type 2 diabetes. What's really changed over probably the last 20 or so years are all the options. Now diabetes is not, we have insulin and we have one tablet to treat you. We have multiple different treatment options to really customize for patients. Medications are also geared now to help people who are overweight with weight loss. And all of these really provide huge benefits as well as a reduction in cardiovascular risk for people with type 2 diabetes. For people with type 1, the biggest advances have been, first I would say in newer insulins, which for many people relieve burden of self-care in many ways in terms of making it easier to manage diabetes around meals. But what's also been revolutionary, I would say over the last, about 10 to 15 years, is the advance of technology. Really leveraging the use of technology to manage people with diabetes. We see now every day in our care, use of continuous glucose monitoring, which as an aside is also now available for people with type 2 diabetes. And what that does is it gives a patient, instead of just fingerstick testing, a full window into what's happening with their blood sugar levels 24/7. One might, with just simply 4 finger sticks a day, not realize blood sugars are going up after a meal. With glucose sensor technology, and there are multiple different options to meet all different patients' needs, a patient can get a full picture. That's not it though for people with type 1. How hard is it to think about if you make no insulin to really be able to have a system, which are what we now call artificial pancreas systems or automated insulin delivery systems, to help manage your blood sugars. Diabetes is a 24/7 condition for people with type 1. They never make insulin at this moment, and their body can't always respond in the appropriate fashion after they eat a meal. What these systems do is, I like to joke and say, clean up the mess. And what do I mean by that? You're eating a meal, you're not exactly sure what's in it, it's a complicated meal, you're at a fancy event. If you do okay with your meal dosing, the system will fix the rest. This is huge. It markedly reduces patient burden, enables people to have better sleep overnight, and has really been revolutionary. And even for people who don't choose to wear the automated insulin delivery systems, there are other options with, as I mentioned, glucose sensor technology and smart pens. So technology has really revolutionized the care of people for type 1 as well as type 2. All right, let's not forget another population of patients, which are pregnant women with diabetes. Diabetes during pregnancy, which is an area of interest of mine, can impact women with pre-existing diabetes, type 1 or type 2. And also there's a condition called gestational diabetes where people are diagnosed with diabetes during pregnancy. Based on some of the work we've done in all of these areas that I've mentioned to you, there are now new treatment options offered to women with gestational diabetes. Women with gestational diabetes had all of a sudden diagnosed, had to manage their blood sugars, start fingerstick testing, do everything while they were about 30 weeks pregnant, 28 weeks pregnant. What a burden, you're already pregnant. Now, glucose sensor technologies, in part due to the research that we've done, are approved for use during pregnancy in women with diabetes and gestational diabetes. And this is a huge relief in burden. As an individual who has had 2 pregnancies, I know it's not easy, but this makes a huge difference. Yeah, so my research in type 1 diabetes has been rather broad, and interestingly, we're now also expanding some of this into type 2 diabetes as well. What I started with in my career as a researcher was trying to really focus on how can we improve the lives of people with type 1 diabetes. I've already alluded to some of the burdens of self-care that can occur. And what we really have worked on, and we were in some of these first original studies looking at artificial pancreas system technology in the management of people with type 1 diabetes. These initial studies were hotel studies testing novel systems that were not FDA approved. And now here we are many, many years later. We have many options and treatment opportunities to offer people to improve care. So the research has been really important in terms of leveraging this technology, coming up with patient satisfaction tools to ensure we're really meeting everybody's needs, and also focusing on healthcare disparities. What will also state as an interest of mine is actually within that pregnancy realm, as I already alluded to, how to care for pregnant women with type 1 diabetes. An incredibly challenging time, very tight blood glucose control, increased risk of hypoglycemia. How can we relieve that burden? And that's what a bunch of my research is focusing on now. And we literally just completed studies using a system that's specifically customized to manage blood sugars during pregnancy in women with diabetes. It was unbelievably exciting to present some of that data at a meeting in Germany over the last few months. And I can't wait to see that publication out to really show people that this can be done. So in terms of what advice to give people to live a normal and healthy life, this is a hard one. And what would I say? Keep focused. And if you lose focus, get back on track. What do I mean by that? This, for better or for worse, you've got your physician and healthcare team supporting you if you have diabetes, but this is a daily condition that requires home self-care. You have a bad day, you forget to take a medication, don't say, okay, well, forget it, I've given up. Stay on track. Know that you've got a healthcare team supporting you, and know that there are treatment options that can be customized. What I always say to my patients, and I really mean this for all people with diabetes, it's not that you're failing the treatment, it's that the treatment is not working for you. There is always a treatment that we can come up with to work within your lifestyle to make this work for you, and we can accommodate what all people need to make this better. Work with your healthcare team, focus on where you're struggling, and iteratively come up with ways to improve or come up with a fashion to make this better. And this is what I say to every one of my patients every day. It's not that you failed, it's that we failed you if we haven't come up with the right treatment option. So the ADA, or the American Diabetes Association, has been an extraordinary support mechanism for all of us as physicians and their patients with diabetes. ADA does tremendous focus on education for physicians at annual meetings, so I learn more about what's going on. For patients in terms of educational resources. For outreach in terms of making sure that patients have care that they need. So it's patient education, physician education, grant support. All these are critical in terms of really ensuring that we meet patients where they are now until we really eliminate this disease and come up with cures. So it's a true honor to be named to receive the Harold Rifkin Award. Dr. Rifkin was a pioneer in his times, and this is going back to the days of the 1950s and the 1960s, where basically all one had to treat people with diabetes was insulin and one tablet. There weren't even finger stick testing back in those days for those of you who may have diabetes. There was very little, but Dr. Rifkin was incredibly smart and did the research and started to have the questions and the answers. He had an incredibly robust practice in New York City, and I know this because his reputation preceded him. He believed in tight glucose control in days where all we had was urine testing, and he really motivated and collaborated with his patients. He provided hope to them, and the Harold Rifkin Hope Award is what I hope that I do for my patients. So at Mount Sinai, even for patients not under our care, we try to offer them opportunities to learn. Patients are always welcome to come in and see us, but what we have now in place, and we started this well pre-pandemic, are classes, educational classes for all people with diabetes. You want an appointment, you can contact our office and we can set that up for you, free of charge. It also becomes an educational session as well as a support group. We have nurse practitioners, nurses, and diabetes educators, as well as dietitians who come. We even had cooking classes in some of those. During the pandemic, we turned those virtual so that people felt safe, but they became a lifeline for many of our patients. So we provide this support free of charge, available to all, because we know how important it is for people to gain those educational tools with diabetes.